Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Japan, Professor Ichiro Takumi. Professor Takumi is a professor of neurosurgery at the San Mariano University School of Medicine, Kawasaki, Kanagawa, Japan. He is also the deputy director of the Parkinson's Disease Treatment Center and deputy director of Epilepsy Center there. He is a member of the Committee of Japanese Society for Neurology and International Committee of Japan Society of Stereotactic and Functional Neurosurgery. His clinical interests are focused upon stroke, functional and epilepsy surgery. He is a recipient of several awards in his country for his outstanding contribution to neurosurgery. He is also a noted author with several publications in various peer journals. We are extremely honored to have him today at our webinars, and today we'll be talking about surgical management of temporal lobe epilepsy. The speaker for the second session is our honored guest from China, Dr. Jingui Lin. Professor Lin is an associate professor of neurosurgery at the Ningbo University affiliated First Hospital. He is a member of the Youth Committee of Neurosurgery branch of Zhejiang Medical Association. We are extremely honored to have him today at our webinars, and today we'll be talking about application of intraoperative infrared thermography in bypass surgery for adult myomer disease. The chair for the first session is distinguished faculty from India, Professor Mallabhaskar Rao. Professor Rao was the previous chairman of the National Institute of Mental Health and Neurosciences, India. He is an easy member of the Indian Epilepsy Society and also the president-elect of the Indian Epilepsy Association. He was the past president of the Indian Society of Stereotactic and Functional Neurosurgery and past continental vice president of the World Society for Stereotactic and Functional Neurosurgery Committee of the WFNS. He has received several grants for his various international projects and is also a noted author with several publications in various peer journals. We are extremely grateful to him for accepting our invitation to chair the session of Professor Takumi. Chair for the second session is our honored guest from China, who is also the vice president of the ACNS, Professor Shubin. Professor Shubin is the consultant neurosurgeon at Huashan Hospital, Fudan University, Shanghai, China. He is a world-renowned faculty who leads a number of bypasses for Moya. He is also the torchbearer for online education in China. And we are extremely grateful to him for accepting our invitation to chair the session of Dr. Lin. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and all the wonderful audiences who have joined us to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Liu Bun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this podium to our first chair, Professor Mallabhaskar Rao.
Good day to all of you. Thanks to the leadership of the ACNS for the opportunity given. A very brief overview about epilepsy. By conservative estimates, there are about 70 million people with epilepsy in the world, and about 20 to 25 million of them have drug-resistant epilepsy. One of the most common substrates underlying drug-resistant epilepsy is mesial temporal lobe epilepsy associated with mesial temporal sclerosis. Most common epilepsy surgery performed worldwide is anterior temporal resection. So I urge all the participants of this webinar to learn the intricacies of the anterior temporal resection from our distinguished speaker today. Not only you can help the people with epilepsy, but also once you learn the anterior temporal resection for epilepsy, you can also do surgery for tumors, surgery for vascular lesions, AVMs and aneurysms, and even trauma surgery. You can perform better once you understand. With that very brief introduction, over to the speaker to start his presentation. Thank you.
Good afternoon, everybody, to you. Thank you very much for me to have this opportunity, especially Professor Kato, to appoint me as this afternoon for me to have this talk about the surgical management of temporal lobe epilepsy. And thank you, Professor Rao, about the kind of introduction about the temporal lobe epilepsy. But today, I'm going to talk about the very basic for, especially for the youngsters to start as an independent epilepsy surgeon, and there's nothing to disclose. In Japan, almost 8,000 neurosurgeons are qualified by our society, and out of that 8,170 are also qualified as an epilepsy specialist. So we say this is an epilepsy surgeon, and we are the independent. But there's some peculiar situation in Japan is that the adult patient with epilepsy is almost many percentage are taken care by the regular neurosurgeon or the epilepsy the neurosurgeons. Not many epileptologists are working here. What I mean is the neurologists are not very much not very much number of neurologists are specialized in epilepsy. So we have to take the patient with epilepsy by ourselves. This is a survey which happened in the year 2016. Although all the cases are not included, but like my cases are not included in this surveillance. So we have roughly 1,200 cases of epilepsy seizures per year, which is a little bit lesser than we are expecting. And among them, VNS surgeries are like 400 to 500. So the regular surgery for the epilepsy is about 700 cases per year in Japan. So in order to overcome this, not only the reasons, we have a government-supported epilepsy-based hospital system. We have started this system since the year 2015, and now we have 27 base hospitals in Japan. So like this, we try to keep the good number of epilepsy surgeries. And as Professor Rao pointed out in the first place, 30% of the patients with epilepsies are refractory, drug resistant, but these are not the good numbers for us to consider about the epilepsy surgery, because as I said, the number is just only 1,200 cases. So we have to be very specific about what we are doing. We used to say the 2 drugs, 2 years rule before, with the most appropriate, using with the most appropriate anesthesia medicine, with the 2 types alone in combinations. We have to first do the medication. But these days, we also in Japan, in Japanese Epilepsy Society guidelines says that we have to be very much decide if we introduce the epilepsy surgery in a shorter period of time, especially in children. And this is a very famous classic work from Samuel Reed about the randomized controlled trial of surgery for temporal lobe epilepsy, with the seizure, this is a surgery group and this is a medical group. These are the same, the seizure-free period here. But when we see this graph, both impaired awareness seizure and older seizures are much better in the patient who underwent surgery had better seizure control. But that's not the only case. The patient who underwent surgery had better quality of life, employment, and schooling status if we put the scoring for the epilepsy surgeries. But we have to be very reality about the epilepsy surgery. This is a very wonderful paper from Lancet paper in the year 2011, that even after 7 years, let's say 7 years after the surgery, some case has to have the epilepsy. Those cases who didn't have the epilepsy last year, but after 7 years comes suddenly to regrows the epileptic seizure, re-see the epilepsy seizure again. So the overall, they have calculated anterior temporal resection. Estimated percentage seizure-free at 10 years is just 49%, just less than 50. And this is a reality of epilepsy surgery, which we have to be very careful about it. Now, let me take a look at the focal impaired seizure. This is a case of a 43-year-old lady with a history of 11 years of drug-resistant epilepsy. She had past history of meningitis at 6 months of age. Looking at the MRI scanning, the left hippocampus has a severe atrophy compared with the contralateral side, but both of them are affected. This is FDG PET scanning, and the tracer is less seen in the left side in the medial the structure, as well as the lateral cortices as well. And she had a cognitive decline by the measurement of vascular intelligence scale and vascular memory scale. So we put this case in the epilepsy monitoring unit. Now, epilepsy monitoring unit is very, very inevitable for us to do the evaluation of epileptic seizure. We have seen that from the anterior temporal, the epilepsy, the ictal discharge started. Now, the youngsters have to know that this EEG monitoring is average referral settings of the EEG, not the regular bipolar or monopolar settings, which is this setting. So if you change and control the derivation of the electro EEG settings, it is much easier for us to evaluate how the EEG shows us. And this is not very much difficult if we very much familiar with it. So the diagnosis is that in this case, temporal lobe diagnosis is temporal lobe epilepsy. That's right. It looks like the left side because MRI and the FDG PET and the phase 1 monitoring is showing the same side. And mesial structure is affected. And from the history of the patient, focal to bilateral tonic-clonic seizures not as many. So we would like to go to the temporal resection. Now, when we compare the anterior temporal lobe resection and selective amygdala hippocampectomy, these days ATL, anterior temporal lobectomy, may tend to be selected because the volume of surgery to be treated is larger than the selective surgeries. But I assume but to the contrary, this is the matter of pre-surgical diagnosis is not enough for us to select which patient is okay for the ATLs, which is the patient is okay for the selective surgeries. But anyhow, our method of mesial structure resection is doing the microscope or exoscope with the anterior structure, especially in the selective surgeries. And recently I put an 30 degrees endoscope for the posterior structures to keep the surrounding cortices not to have the visual defects. We unfortunately do not have a laser institutional thermal therapy in this country, in Japan. LITT should be very much looks like a very less invasive and very much promising. They have a good promising data, but we do not have a LITT system approved in Japan. So we still have to have a selective seizure as well. This is a small survey that I have done with my mentor, Professor Eiji Watanabe and Professor Akio Morita. And at that time, we in Japan, selective surgeries and anterior temporal lobectomy, the numbers are almost the same. And and the reality and the cure rate is almost the same, over 80%, 89 to 81%. This is the ideal surgery. And this is the green thing. Green thing is the mesial structure. If you look out of the cortices, and this is an experimental setups for the using the transvisible navigator, which is mainly done with my mentor, Professor Eiji Watanabe. And with this TVN system, with combining the augmented reality, we can imagine what the media structure is. And so this setting is, I think, very good for the education for the youngsters. Nowadays, we're using a lot of exoscope in Japan, and we have created a very light tracker for the system as well. But the augmented reality has to augment too much information, so it's a little bit still difficult for the super accuracy. You can see on the right side. And this is the actual surgery of anterior temporal lobectomy. And we can cut at the T2 level, like this, transfer incision or the vertical incision, whichever is okay to start to cut the lateral piece of the temporal structure. This is a view with the exoscope, so it's easier for us to see the temporal tip. With the microscope, this view is hardly acquired. But taking the temporal lobe piece by piece, we can approach to the mesial structure. Now, now we are in the inferior horn. Now this is our hippocampus, very smooth surface. For the observation from the in the long axis, and do the surgery to reject the mesial temperature, mesial structure, to reject the mesial structure. Now, this looks like very easy approach, but I would say this is not at all easy approach, because we have very small factors of surgical landmarks. It's very hard. We have to be very careful about the degrees of entry to the inferior horn. So I assume this is not a easy technique as well at all. We have to cut the mesial structure from the lateral of the innominate sulcus, which is innominate sulcus, which is a collateral eminence that I have seen, and going to the mesial side, we have to do the surgery one by one. Now, this may have a good view for the to have a good view for the safer maneuver. But for the selective surgery, I would say to do the one piece by piece technique is better. Unlike most of the neurosurgeons who like these techniques, keep saying that we have to take the mesial structure at one piece, but I would say that piecemeal resection is okay with me. Well, now my mentor is Professor Watanabe, who has been co-working together with Dr. Mayanagi, and so my transcervian technique is a transcervian transankle entry, which is a little bit different. This is also different from the other neurosurgeons who likes to do the anterior selective surgeries. This is an uncos, and I try not to use no metal brain detractors, and we approach to the inferior horn from the uncos. I prefer this surgery for several reasons, but one thing is that we have a good surgical structures for the landmarks. It is easier for us because for the transcisternal approach, we are very much familiar with it when we do the aneurysm surgeries. But I have recently combining this with posterior resection with the endoscope, because if we use the endoscope for the posterior structure resection, I do not have to injure the Maya's loop to preserve the visual field. So once again I have to concentrate. I have to focus to saying that the piecemeal resection is very important. This is hippocampal artery, which is going to the hippocampal sulcus, and looking at this hippocampus looking at this hippocampal sulcus and this arterial structures, we have to have a very good view. So in order to have a good view, we have to have so one of my my answer is to do the piecemeal resection. And I also take the superior aspiration of the anterior portion of the oncus before going to the resection part. And this is view with the exoscope. And we can do the this surgery with exoscope. Not very much difficult, and the exoscope has a very much nicer place compared with the microscopes. But if you have taken out the anterior part of the oncus, which is we can have a very good view for the mesial structure resections. So these days we are taking this. So this approach, we are very much familiar with the surrounding structures and anatomies. So I prefer this technique and approach. Once again, supine aspiration of the anterior portion of the oncus makes us the very good surgical corridor if we do this before the mesial structure resection. If you do not do this supine aspiration for some technical reason, the surgical corridor is very small and makes us a little bit harder maneuver. So this is another case of without doing the supine aspiration of the anterior portion of the uncus. So it's the area of resection is the surgical corridor is shallower. So recently I try to do as much as I can. We sometimes see PCA branches for this approach, so we have to be very careful about it. And during the resections, I do electrocorticogram with the hippocampal electrodes with certain settings of the self-fluorine at the endotidal percentage of 2.5%. With this, putting these small electrodes onto it. The meaning of this measurement is like in this case, the electrode 2 or 3 is this and this, and so this adjacent hippocampus has to be included in the resection. So I always do the ECG with this hippocampal electrodes for the resections. when we did the analysis of mesial structure rejection of the length of mesial structure rejection, the average length from the tip of the hippocampus is 23 millimeters, so almost enough for me to think about, because I was told from my mentors to cut to do the rejection as long as 25 millimeters for some reason. And the very good point about this approach is a very little visual defect, and this is the worst case in my series by looking at the Goldman perimetry system, and almost some cases, in most cases they do not have a visual defect, even with the Goldman perimetry system. We still have transient oculomotor nerve palsy in the earlier case, or transient trochlear nerve palsy with this technique. Professor Yashiju said in his paper that avoid brain retractor use, and so this should be very in some settings is very important, I think. And in some paper, the visual defect is observed in many cases, which is a little bit a different method of measurement of Humphrey. Our approach superior, just in terms of to preserve the visual not to have a visual defect. And interestingly, this is from Brazilian group. They have once did the trans-oncus approach, and also did they said a supine aspiration of the anterior portion of the ancus, which we are also taking this part. They have also said the same idea. Doing the same surgery with the same idea, but they have sadly abandoned this approach because they have observed this atrophy postoperatively. So, but the difference of these groups and our group is. We do not use a self-retaining retractor, and we are using the piecemeal block resection to preserve the temporal lobe itself. So we have to see if this kind of atrophy occurs in the series, but so far we are not seeing this very much in a group of patients. We have a good preservation of visual field, and luckily enough, we didn't have a permanent hand paralysis out of our approach. We can do this approach with the combination of exoscope and endoscope, which I think is a very good way of doing in comparison with using the microscopes. The small referral about the evaluating the mesial structure involvement is we use a lot of direct depth electrode into the hippocampus. This is we can do this approach on the phase 2 trial of invasive long-term video EEG monitoring. We can have 2 boreholes for bilateral evaluation. One strip on frontal, one strip on the temporal base, one direct depth to the hippocampus for the evaluation, and we can do this for the bilateral settings. And if we have seen this in the one side of the hippocampus, and we can now decide which side to be rejected. This is an alternative technique from a Japanese textbook written by Dr. Michiharu Morino. He is a very famous Japanese epilepsy surgeon, and in his paper, he didn't have to use the stereotactic apparatus for the depth electrodes. Instead of that, he is using the T-shaped electrodes. Maybe this idea is coming from Professor Shimizu, who has been his mentor for a long time. And cortical mapping should be considered for the case with these for the case with these lesions. But the thing is, if we can reject this this lesion if we find out this is the focus, and if we found out that this is the focus, this electrode 21 is the focus in this patient, and there's nothing to do with the hippocampus mesial structure in this case. So we decided to consider if we can reject this number 21 electrode 20 number 21. So the question again is, can the focus in electrode 21 be rejected? This is a language dominant hemisphere, and it looks like the distance from the tip of the temporal lobe is about 6 centimeters, 5.5 centimeters, which is to say in the dominant side, 4 to 45 millimeters is the regular margin for the anterior temporal lobe resections. So in order to see, we have to do the language mapping for these clinical settings. So what we see here in the first language task is with the stimulation of this focus point. There's no speech arrest or kind of thing. But if we do the stimulation on the 7 or 8, we consider this is a language center, and there's a speech arrest during the stimulation. So we cannot do the the rejection of this area. So in the language mappings, we are preparing the 6 different tasks for the these kind of language mapping, and we say that definitive language areas with positive simulation findings in 5 or 6 categories. So with this case, we were able to do the degenectomy only with the degenectomy mesial structures preserved, and the pathology was oligodendroglioma, no seizure after 11 years post-operatively. Anti-seizure medicine continues same as pre-surgery, and the IQ goes from 61 to 89. So this is in this case, seizure have stopped and brain function has been restored. So these are the very basic about the temporal to consider about the temporal lobe resections. As for the time consuming, I would have to stop my talk here. But there are other topics to be considered for the temporal lobe epilepsies treatment. How do we evaluate ECOG? ECOG electrocorticogram. How much can we skip intracranial electrodes? Or we have to be very careful about mimicking epilepsy like insular epilepsy, and we have to have the problem or the issue about MST, cortices or the hippocampal MSTs. Or recently we are importing the idea of stereotactic EEG from the United States, but these SEEGs have been done in the Italy or France from 1970s or 80s. So our classical technique of combination of depth electrodes and grid or subdural grids which is a superior kind of thing. And I do not do much of the electrical stimulations, but in some group in the world, especially in France, detection they're using it for the seizure to detect the seizure focuses, or the direct hippocampus stimulation is done. So to conclude, especially for the youngsters to start as an independent epilepsy surgeon, I would recommend to find an epileptologist to work with you, or to become an independent epileptologist by yourself. The second thing is EMU, epilepsy monitoring unit, should be used for seizure analysis and unite the team. Documented seizures are truthful and important in determining treatment. And number three is epilepsy surgery is either curative or palliative surgery. I have shown you the curative surgery, but try to find any small benefits you can provide to your patient. And lastly, try to find one case of major temporal lobe epilepsy with non-language dominant side and talk with your neighboring specialist. This is our team, and thank you very much for your kind attention.
I think, Professor Takumi, this is one of the best talks I heard on surgery for temporal lobe epilepsy, and congratulations for all the good work you're doing.
Thank you very much.
Please allow me to make few comments for the benefit of residents and young participants. You mentioned that, Dr. Raja, how much time we have?
We have 10 minutes.
Okay, good. So you have mentioned that you are presenting very basic epilepsy surgery, but I think you showed us some of the advanced techniques. You are fortunate enough to have everything at your disposal. Now, there are hundreds and thousands of deserving patients are there in Asia and worldwide. Many young neurosurgeons are keen to learn and do epilepsy surgery, but they do not have all the advanced technology which you have. What is your advice to young surgeons, how they can build?
Yes, thank you very much for your very important question and comment. And I totally agree with you how the young neurosurgeons are considering. But what I can say is each youngsters have to consider whatever they can do in their own settings, because I cannot do import something from the number one epilepsy center in the world, or let's say it's located in Japan, in the US, in Europe. I don't know, but I can only do what I can do. So first of all, I advise those youngsters to consider what they can to try to find what they can do by their own settings. But the very important thing is to reject which part, or is it okay for us to do the reduction surgery for the patient with epilepsy in front of myself or themselves? So the very important thing is to record their seizures. For that, so that you or they can analyze even after the surgery is over. So the recording of the surgery is one of the most inevitable things.
Yeah, very true. In fact, just like how surgery became very sophisticated, even electrophysiology became very sophisticated, especially with all the high frequency oscillations and so many recent advances in electrophysiology. So neurosurgeons have to some extent collaborate and depend on neurology colleagues. I know in Japan you would like to learn and develop expertise in all these areas, but much of the developing world, the neurosurgery and neurology are developing parallelly. So one has to collaborate with others. Now, another important thing, these young neurosurgeons, when patient comes to their hospitals with temporal lobe epilepsy, they're ready to do temporal lobe surgery. But these patients are hidden in the community. So many things look like temporal lobe epilepsy. For example, orbitofrontal, occipital, insular, mesial temporal, temporopolar. So many epilepsies look like classical temporal lobe epilepsy, and then one should not do surgery for a wrong indication. So indications became very important. So how proactively you speak in CMEs, you convince neurologists, how do you convince patients, how do you convince families, how do you convince doctors, how do you get your referrals? What do you do? What techniques do you do?
Yes, today I didn't show, but one of the things I'm taking into our settings is MEG, electrogram, MEG examination, which is kindly done by Dr. Kaneko in Tokyo. He is a very famous gentleman, and I have been collaborating with this gentleman for more than 15 years. So the MEG is another very important factor for us to consider. But the most important thing is, we cannot decide the surgical indication by ourselves. So we have to unite the better team. And I think we have to focus on creating the better team with epileptologists. And in my settings, there is no neurologist with epilepsy specialist. So I'm talking with my young neurologist to be someday to be an epilepsy specialist.
Yeah, of course. In India, there are two centers have got MEG, including center, and Professor Nakasato is a friend of India, and he visited our center, and then we collaborate with him.
Oh, great!
And now, regarding the surgical technique, you have used microscope, you have used exoscope, you have used endoscope, but all the centers may not have the advanced technology. So I urge young neurosurgeons to learn to do this technique under microscope. Of course, when they get more and more technology, they can use other things. I beg to differ with you in one aspect of surgical technique. See, two factors are very important in prognosticating the long-term outcome of epilepsy surgery, temporal lobe resection. It helps in counseling patients. It helps in reducing the drugs over a period of time. These two factors. One factor is postoperative MRI showing complete resection. Second factor, histopathology showing hippocampal sclerosis. When we do piecemeal resection, we using QSA, the specimen is fragmented, tissue is fragmented. It is very difficult for a pathologist to give a diagnosis. So that is one of the very important prognostic factors. So I think young neurosurgeons should learn. They can do cadaveric practice, they can do simulation, anything possible, but they should learn to do en bloc resection. That is one very important technique. Over a period of time, this is a sclerosed, hard, firm hippocampus. One can learn the technique of en bloc resection. So please pardon me for highlighting this point, because you mentioned that you prefer piecemeal to avoid deficits. I agree with that point. You can avoid retraction, you can minimize the deficits, but we lose the histopathology. If tissue is fragmented, pathologists will find it very difficult to this one. And of course, I've seen some of our Japanese colleagues doing excellent MST of the hippocampus. You just mentioned as a passing remark at the end. Anyway, I think a lot of useful and important points you have mentioned. My final comment is that when you, I, and others present our experience, like for example, you have sizable experience. I have done more than 1,000 temporal lobectomies. When we present this experience, it looks very impressive. But the fact is that there are hundreds and thousands of people are waiting, and a huge number of backlog is there. And then it should be like one of the common neurosurgical procedures. This is a very elegant procedure. Every neurosurgeon who is doing microsurgery should learn this procedure, and then they should do anterior temporal resection. And if you have any final closing remarks, please mention, and then we'll hand over to Raja for the next session. Thank you very much.
Thank you very much. Thank you for the wonderful comment, and I'm still on my way to find to the better surgical technique, and someday I want to talk this kind of another improvement of myself together with you, ladies and gentlemen. Thank you very much for this time to have this opportunity. Thank you.
Thank you. Thank you.
Then we can move on to Professor Shubin. Any comments?
Professor Takumi, nice presentation. Thank you.
Thank you very much. Thank you.
Any questions from my co-host, Liu Bun Seng?
Thank you, Raja. Thank you, Professor, for very nice lecture. I have 3 short questions, Professor. One, I think Professor Mala mentioned, what are the requirements for the specimen to be sent to the pathologist? Because we used to know that we need to send hippocampal structure, amygdala structure, anterior temporal structure to the pathologist. So in selective amygdala hippocampectomy, would the piecemeal removal be accepted by the histopathology? My second question, Professor, regarding amygdala resection, how do we decide how much amygdala to be removed in the surgery for the best epilepsy outcome and avoid a deficit? My last question, Professor, this is a usual problem. How much tail to be removed? And Professor mentioned that you use ECOG. Do you use ECOG for all the cases, or you use many IGS or anatomical landmark to decide how much tail to be removed in your surgery? Thank you, Professor.
Thank you very much for your question. It's very difficult for me, some of them, for me to answer. But about the extent and the length, I said 3 to 4 piecemeal resection, but at the same time, because of my past many criticism from my pathologist, I try to take as much as less than more than 15 millimeters of anterior as a mesial structure at one piece. The reason because I'm using I keep saying the piecemeal resection is because as it was pointed out, I think the surroundings, the preservation of the surrounding structure is at the same time very important, and I wanted for the youngsters to be noticed about that point. The specimen is very much important, but the important thing is not a specimen, but the patient, her or himself. So I keep saying that. So the basic idea of the pathology is almost the same as the other neurosurgeons, of course. And for the extent of the amygdala, I just only do almost the same surgery to minimize the surgical injuries. So I only do the resection. And the third part, what was the third part?
How much tail to remove, Professor?
How much what?
Tail. The tail of the
tail.
Yes.
Yes. So the tail should be, the length of the tail is as we have looked at with the software. The length is 23 millimeters from the top. So the length is not very much longer than the regular surgeries, or even a little bit shorter than the regular selective surgery entering from the more posterior part. But we think at this moment, we think this is almost the same as we have done in Professor Mayanagi's group with the regular settings. Almost the extent is almost the same.
Thank you very much, Professor.
Can I add a comment?
Please.
Please.
So complete resection of hippocampus, complete resection of amygdala is good to cure epilepsy, but bad in terms of neurological, cognitive, and neuropsychological deficits. Amygdala, the superior part of amygdala merges with globus pallidus. There is no demarcation. You cannot say that amygdala is ending here, globus pallidus is starting here, because they merge with each other. So superiorly, there is a limit. And then same thing, medially, there is an optic tract. So if small perforators of the optic tract are injured, there can be major visual field defect. So superior part and medial part of amygdala is not resected. But there are cases where radical amygdala resection is indicated. If patient has got an ictal fear as a manifestation, and if preoperative MRI shows amygdalar atrophy, then the most probably the focus is amygdala. In that case, amygdalar resection has to be radical. And also there are some instances where hippocampal function, memory is preserved. So there also we cannot do complete resection of the hippocampus. When there is a limited hippocampal resection, as a compensation, we do more amygdalar resection. Of course, hippocampal resection, more is better, but again, there are deficits are there. Thank you very much.
Thank you.
Thank you.
Ben, any questions from you, Ben?
Yes, and thank you so much for these very informative lectures on epilepsy surgery. So I saw neurosurgeons from Brazil also do a infertentorial supercellular approach to the hippocampus. So I saw you also use exoscope and endoscope. So in some scalp-based surgery, we find this approach is actually quite useful when you use the combination of exoscope and endoscope in the infertentorial supercellular route, aiming at the posterior canal region. So do you have any experience of the use of this endoscope and exoscope and with supercellular infertentorial approach to the parahippocampus?
Personally, I don't.
Can I answer that question?
Yeah,
so the approach which you have mentioned, supracerebellar infertentorial, is popularized by Professor Ugur Ture from Turkey and few other neurosurgeons. Why Ugur Ture is doing that approach is that he has got hundreds of cases of experience in operating on midbrain, hundreds of cases of operating on thalamus. So this is one of the most common approaches for Ugur Ture to reach thalamus and midbrain. Yes. He is using that experience in epilepsy surgery. For somebody who is not familiar with that approach, to learn and then get orientation to mesial temporal structures, for beginners it is difficult. Of course, if there is a lesion, discrete lesion in the posterior parahippocampal gyrus, posterior tail of the hippocampus, maybe we can try, but it has got only few neurosurgeons worldwide are using that approach. Thank you.
Thank you. And I have another question. It's about the use of the, how would you choose which modality of invasive monitoring you use? For example, you can have a subdural grip insertion and then monitor the EEG. Another way to do is do a SEEG. So there are so many different choices. So how would you choose which one is the best for the postulating the theory of the epilepsy in your center?
Well, I do not have the answer, but the thing we are doing is a combination of the depth electrodes and subdued grids still. But you know, we also are learning in the learning process of SEEG, the thing. But the SEEG analysis, the goal, I think, is the lobectomies, or to define the which part is not able to do the surgery. So the object of those two different strategies are a little bit different. We have to be very super selective for the less invasive surgeries, but SEEG is something different. It's more focused on the cure by the bust the more volume of doing the resections. Which, yes, please.
No, after you.
Thank you. But which is a little bit difficult for the Japanese population or the culture to have to do the the radical surgery, especially for the epilepsy. And I think we have to consider about the cultural background. And for that, SEEG still is we are very waiting what we can find.
Yeah, I have a couple of points. If the question for implantation is to decide whether it is right or left, right temporal lobe or left temporal lobe, or if it is mesial temporal lobe or lateral temporal lobe, if that is the question, then subdural strips and depth electrodes are enough. But if the question is it insula is involved, is it opercular involvement is there? So it is like a temporal lobe epilepsy. There is temporal plus epilepsy. There is a pseudo-temporal epilepsy. So if you are suspecting surrounding to mesial temporal, then stereo EEG is useful. See, this so-called subdural strip, this will not sample from the insula. To precisely know from insula, because much of insular epilepsy manifests as temporal lobe epilepsy. If you suspect insular epilepsy, then I think stereo EEG has got an advantage over the strips and depth electrodes.
I see. Very important comment. Thank you so much.
Thank you very much, Professor Rao and Professor Takumi, for teaching us advances of epilepsy surgery. Now it's time we'll move on to the second session, and before that, if I invite Professor Shubin to let us know the number of participants.
Today we have more than 550 audience in the WeChat.
Thank you very much. We are extremely grateful to Professor Shubin for this. We'll move on to the second session. I'll hand it over to our second chair, Professor Shubin.
Okay, now let's give time to Associate Professor Lin Jinghui. He comes from Ningbo University, affiliated First Hospital. So today his topic is the application of intraoperative infrared thermograph in bypass surgery for adult Moyamoya syndrome. Their primary study, because this is another choice besides the ICG, because ICG is high demanded to the microscopes.
I'm Lin Jinghui. I'm from the first affiliated hospital of Ningbo University. I'm going to share my working experience and research. My topic is application of the intraoperative infrared thermal in bypass surgery for adult Moyamoya syndrome, a preliminary study. Vascular bypass. This technique is mainly applied to the reconstruction of the cerebral blood flow, and it's used to solve various complex cerebral ischemia problems through three methods. Among them, Evaluating the patency of the anastomosis is the key to success surgery. The commonly used method include the follows: Hypercapnia test, DSA, and microvascular ultrasound Doppler, ICGVA. The hypercapnia test, its advantages are faster and easy, no reliance on additional equipment. The limitations is the lack of objective evidence, easy to tear and damage anastomotic blood vessels. Generally, we only use this method in animal labels. We only use this method in animal laboratories. This is the case: a male, 60 years old, chief left headache caused by a car accident with confusion for 4 hours. The labor veins is contusion and disconnection. After clearing the venous thrombus, we are anastomosis the blood vessels. Let's see the video. Although we do not have equipment available to assess the patency of the anastomosis at this time, we still do not apply blood test to vascular the patency of anastomosis. There are some advantages. Microvascular ultrasound Doppler can assess anastomotic patency by quantify vascular hemodynamic data, and no need for injection of contrast agent, easy to ablative. This is another case: female, 66 years old, 2 years after embolization of right pica aneurysm, recurrence and found on DSA. Our surgical plan is OA to pica and two-side anastomosis protective bypass, and the aneurysm embolization or aneurysm clamping or proximal occlusion of the parent artery. Let's see the video. We separated the OA between the muscles. And do the end-to-end bypass. From OA to pica. Then we finish the bypass. We evaluate the patency of anastomosis using the ultrasound. After completing the bypass, we use the DSA to confirm the patency of the anastomosis. We choose the treatment of aneurysm with embolization. There are some limitations. First, the ultrasound Doppler techniques place too much emphasis on global vessel angle, and the measurement at the different angle will give various result, make the result too disparate. Secondly, microvascular ultrasound Doppler does not visualize to the morphology of the vessel and even less sensitive to tiny vessels. This way we use the extra DSA. DSA is considered the standard method for intraoperative assessment of anastomotic patency, and with excellent temporal and spatial resolution. This is the DSA image after we complete the STA-MCA bypass of moyamoya disease in the hybrid operation room. This right topic is DSM perfusing imaging. They have some limitations. DSA is an invasive procedure with a risk of inguinal hematoma and transient neurological symptoms. The DSA procedures is complex and expensive to perform, require bulky supporting instruments and specific operation rooms, and exposes both patients and operation surgeons to radiation. And we can use the intravenous ICGVA. Its advantage are effective and reliable. So it is currently the most commonly used method for evaluating anastomotic paintings during surgery. Excellent temporal and spatial resolution and easy to operate. This is a perisignal sinus meningioma. During the surgery, cerebral venous injury was found, and we sutured the vein and evaluated its patency using ICGVA. This is another case, a male, 65 years old, headache with left limb weakness for a month. The cerebral vein injured during the craniotomy. We trim the venous stumps and do the end-to-end anastomosis. And evaluate its patency using ICGVA. This is another case which we diagnose is moyamoya disease. We do a single vessel double anastomosis for flow augmentation. The ICG can perfectly display complex blood flow relationships after the reconstruction. There are some limitations, which a few patients are allergic to ICG dyes. The perspective of a microscope has a significant impact on imaging results, and it requires the operator to have some experience in evaluating the stability of the anastomosis. If there is a suspicion of obstruction at the anastomotic site during the surgery, adjustment or resuture and reimaging are necessary. It will take at least 20 minutes to ICG to complete metabolized in the previous residual blood vessels. In order to achieve the better display, we also apply intra-arterial ICG-VA. Let's see the video. We can use less ICG. Sometimes we can see very direct and shocking effect. There are some limitations. Also, a few patients are allergic to the ICG dyes. Need to find a branch in donor artery to injection into endothelium green. If it's necessary to reassess the patency of the anastomosis, it will take at least a few minutes for ICG to be completely metabolized in previous recent blood vessels, although it takes much less time than intravenous ICG-VA. So we try to use infrared thermography, which no need for injection of contrast agent. Fast and clear display of anastomotic blood flow. It can be used anytime, repeatedly, and multiple times. We enrolled 21 patients diagnosed as moyamoya disease, qualified for surgery, all of whom underwent superficial STA-MCA bypass. Infrared thermography and ICG were both applied to assess the anastomotic patterns in the 21 patients. This is the infrared camera we used for surgery and some of its parameters. ICG-VA was performed with an operating microscope. In all cases, intraoperative infrared thermography is performed before ICGVA. It has the advantage of visualize the thermal images, harmless, timeless, low cost. This figure shows that the ICG was visualized after ICG injection, and some results were visualized on the infrared thermography of the same patients, but a faster display. This figure shows that a patient with inadequate patency of vascular anastomosis in our study, infrared the thermographic result of this patient after release of the vascular clamp. Imagine results of the ICGVA after the release of the vascular clamp in its patient. Thrombus was found after reopening the receptor artery and was the cause of insufficient patient of the vascular anastomosis in this case. The white arrow showed the thrombosis in the anastomosis. Let's see the video. We can see the anastomosis in this site. When we release the clamp, we can see the patency. We use the saline to lower the temperature of the superficial temporal artery to increase the temperature difference in order to enhance the display effect. In contrast to DSA, infrared thermography is based on the blood flow to visualize changes in temperature modulation to show flow and assess patency. It's an unparalleled advantage to term of both ease of operation and cost effectiveness. To contrast ultrasound Doppler technique, infrared thermography solves the problem of inaccurate measurement and indirect observation of the blood vessels with visualization of the blood flow. Compared to the ICG, where it's intravenous or intra-artery ICGVA, infrared thermography enhances the safety of the procedure without require contrast agent. Clearly shows the blood flow into the anastomosis and can be used at any time, repeatedly, and multiple times. There are some limitations. It's far from perfect technology. One of the limitations of our study is that no corresponding software development applications have yet been seen, making infrared thermography currently only able to show the direction of blood flow and not yet able to assess the distribution of blood flow and perform the corresponding quantitative analysis. Infrared thermography cameras was not implemented into the microscope device and need to be removed before undergoing calibration and evaluation. Furthermore, our study was a single center and retrospective study, which resulted in limited persuasiveness and restricted generalizability. Similarly, infrared thermography can achieve the same assessment effective as RCG, and it's safe and easy to use. Following direct, dynamic, and real-time visualization of cerebral blood flow and provide neurosurgeons with new idea for sense anastomotic paintings. It is like to become more widely used in the clinic in the near future. To the further validate our finding, our next step is to conduct a multi-center clinical trial with a larger sample size. Thank you.
Okay, thank you, Dr. Lin Jinhui. And I think this is a very fascinating. Because now, when you go to the airport, this kind of technique was used to monitoring the temperature, the body temperature. It's the same technique in monitoring the patency of the bypass. So if we can create the software to resolve to mimic the blood flow in this kind of situation, we can solve a lot of problems and with very low cost.
Thank you very much. It is indeed a very novel technique. Like ask you whether do you actually measure the temperature at the cortex to evaluate the bypass?
No, they didn't measure the real temperature of the cortex. Okay. Maybe your suggestion is important. Yes.
Anyway, it is a very good and novel study. Bypass this. Any questions from Ben or Liu? Ben?
Yes, I have a question. And sometimes when we use ICG, if under the microscope, if we cover, for example, if there is something like patties or other things which cover the ICG illustrated area, then you cannot see under the microscope. How about with infrared? For example, if you cover the area, for example, your vessels and the mucus, for example, with some patties or other things in the field, can you still see the signal?
Ben, you mentioned your question is about covered by what?
Yeah, for example, when we use ICG in the microscope, sometimes if for example, if you have something in the field, then you cannot see the ICG, the ICG, the color under the microscope. But how about with infrared? I think with infrared you can see the temperature change, even you cover the field with other material. Is it the real case? I think this is an advantage.
林俊辉就是 Okay, it's similar with ICG.
I see. Huh.
Yeah, thanks, Professor Lin, for very nice presentation. My question is regarding the flow rate. I do not know whether anyone have done comparison between a flow rate measured by ICG video angiography compared to DSA, and if there's any study look at the flow rate with your infrared technique. Thank you.
You mean comparing the ICG with the intraoperative DSA?
Yes, the flow rate, and probably with the infrared technique, whether there's any comparison in terms of flow rate, blood flow rate.
Yes, they sometimes measured in different ways and can get the same result.
Thank you, Professor Lin.
So, Xu, I have another question.
Yes.
And can I just ask a quick question? Sometimes when we do the bypass, we have sometimes we encounter hyperperfusion, but in ICG, it's hard to appreciate it. How about under your infrared thermography? So, is there a temperature change that of the surrounding brain that the signal will have some difference under your infrared?
They are developing the new softwares to measure the real temperature of before and after the bypass of the cortex, just as Raja mentioned. Yes.
Thank you.
Thank you. It was very novel. Just one last question from Joe Sam, who has joined us. He's asking which vessel to inject for arterial ICG in allergic cases. Do we need hemostasis of that vessel after injection?
Dr. Lin mentioned that they have encountered 2 cases after injection the ICG. The blood pressure decreased, and they have to use some drugs to maintain the blood pressure.
Thank you very much. But it is very strange that we never test for any ICG allergies. I have never seen it being done in Japan or where we are currently working. We have never done an allergic test for ICG. It's very interesting that you brought out this point. Well, in case, thank you very much. We'll take the final remarks from Professor Shubin.
Okay, thank you, Dr. Lin, and very interesting presentation. And I think when the technology to use in the intraoperative, maybe the easiest way can be survive, and the least cost way would be a survive. Thank you.
Well, thank you very much. And we'll come to the end of this second session as well. And I'll close this webinar officially on behalf of the Education Committee of the ACNS and the President, Professor Yuko Kata. I would like to thank both the speakers of today, Professor Ichiro Takumi and Professor Lingjin Hui, and the chairs, Professor Malabhaskara Rao and Professor Shubin, for the time and support for the ACNS webinars. Special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and as mentioned, we have over 500 viewers who are joined from all around the world. Special thanks to my co-host Dr. Liu Bun Seng and Ben also, who is joining from Hong Kong. So until we all meet online tomorrow at 7 p.m. Japan time, it is bye-bye from all of us. Thank you very much for joining.